Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. The next thing to consider with dizziness patients in the ED is the issue of neuroimaging. Let's talk just generally about non-contrast head CT. We know there's a low yield for positive findings, generally less than 10%. Despite this low yield, head CT in the emergency department, non-contrast, has a high clinical utility. It's accurate and it allows us to make a disposition that might include being able to send the patient home because we know their head CT is negative. In general, non-contrast CT is the initial test of choice in all ED patients that require neuroimaging. It's useful to exclude subarachnoid hemorrhage, other types of hemorrhage, abscess, space-occupying lesion, edema, mass effect, and/or midline shift. Now, in dizziness, we know that only 1.6% of patients with a non-contrast head CT who are dizzy in the ED will have any positive findings related to the symptoms that they present with. ICH, or intracerebral hemorrhage, rarely presents as an isolated acute vestibular syndrome. And in dizziness patients, intracerebral hemorrhage is only seen in 0.5% of cases or less, that is 1 in 200 or less. We know that if there's a headache and CPPV findings, we should consider CT. The CPPV is a central etiology for what appears to be a peripheral triggered vestibular syndrome, and we're going to talk about that specifically coming up. What about MRI neuroimaging in dizzy patients? We know that DWI, or diffusion-weighted imaging in MRI, can miss stroke in the first 48 hours. So in acute ischemic stroke, a negative DWI MRI can be seen in up to 7% of patients, and in fact, most of these are patients with posterior stroke, which of course is the stroke of concern in patients who present with dizziness. So in acute vestibular syndrome, DWI MRI can be negative in 12 to 18% of patients when performed in the first 72 hours. So we know that MRI can be negative despite the presence of stroke, and that's of concern, and that's why our exam and history must be competent and be able to diagnose likely posterior stroke, because our neuroimaging may not help us as much as our history and physical exam. In small strokes, for example, DWI MRI can be negative in up to 50% of patients, especially early. We know that we should consider large vessel disease in most patients in whom we suspect stroke, in which case doing an initial CT may lead us to consider the need for TPA in the emergency setting. So let's do a question related to dizziness and neuroimaging. Which statement about brain imaging in patients with acute dizziness is true? So one statement is going to be true. In patients with BPPV, a brain MRI can help establish the diagnosis. Doesn't sound like it's true. We know that MRI can miss the diagnosis, especially early. Number two, B, in posterior circulation stroke, CT is diagnostic in greater than 75% of cases. Again, that doesn't sound true. In posterior stroke, CT can be negative quite often. C, in patients with posterior circulation stroke, early MRI with diffusion-weighted images establishes the diagnosis in nearly all patients. That again doesn't sound true because early MRI can be negative, as we just stated. And D, in patients with vestibular migraine, which we'll address soon, neither CT nor MRI is indicated. That's probably true because we know that with vestibular symptoms and dizziness, CT and MRI often are not helpful. So the answer to this is D, neither CT or MRI is indicated. A key point is that not only is imaging not required, but in fact has serious limitations in patients with posterior circulation stroke. So we know that CT and MRI, although assuring or reassuring, they do not help specifically with making the diagnosis, and this was actually seen on page 15 of the monograph. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms; TT, timing and triggers; ES, examination signs; and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the FERNE.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.